Hello, everyone. Welcome back into our interactive NCLEX RN review session. For those who just joined us, we are on day 35 of the 90-day NCLEX review series, and we are doing this for free. And we are inviting you to enroll in our comprehensive NCLEX review course at stancoast.com, where you can access a wealth of resources about over 3,000 NCLEX style questions and 10 hours of animated videos for much more flexible study. And this will help build your confidence. Also, we have a huge library of on-demand videos and also practice exams. So we kindly request that you are going to check our description box below and visit our website at www.stancoastnclexcoaching.com. And for more details, please check the description below. And we always value your feedback. We want to share your thoughts with us, your questions in the comment section, and we will be happy to assist. Now, don't forget to subscribe and also like this video and share to your friends who are preparing for the NCLEX exam. Now, today we will be focusing into our topic on the hypertension and also nursing, all those scenarios that will be able to help you in preparing the exam. So we'll tackle about quite amount of NCLEX questions today. Now, let's get into the discussion right now about the hypertension. So I'm sure that you're quite familiar with this one already, but just want to reinforce of what you had learned in the past. Now, let's go into the different classifications of the hypertension, and this is going to give you a better idea on the different levels and also the severity of the hypertension. And our reference here is on the different levels here, especially for those people aging 18 years old above. The expected range for the adult is basically less than 120 for the systolic and less than 80 for the diastolic. Now, the person is considered to have elevation of the blood pressure, or known as pre-hypertension stage, when the systolic blood pressure is somewhere between 120 to 129 mmHg, and the diastolic pressure is less than 80 mmHg. Now, the person is considered to be in stage 1 hypertension if their systolic blood pressure ranges between 130 to 139 mmHg and 80 to 89 mmHg for the diastolic blood pressure. Now, they're going to be considered in the stage 2 hypertension if their SBP is equal to or greater than 140 mmHg, or let's say when their systolic blood pressure is equal or greater than 90 mmHg. And for those who just came in and joined us in the YouTube classroom, welcome, welcome, welcome. Now, please take note, guys, that if the patient's systolic or the diastolic number falls into a higher category, that's how their blood pressure is going to be classified. And it doesn't mean that when the patient is seen for the first time, and if they have a high blood pressure, then they're going to be diagnosed. No, it will take about a minimum of 2 readings. And of course, the blood pressures will be read in the 2 arms, the brachial artery, okay? And this will be read with some intervals, with interval according to the time. So evaluation from the initial blood pressure reading is very important to establish that diagnosis, as we know that the disease itself can do a lot of serious health issues. It can lead to heart disease, it can lead to stroke, kidney disease as well, and other vascular problems. And so with the hypertension, usually it doesn't show symptoms initially. And some people would really get so frustrated that they've been active in their lifestyle and everything, careful with the diet, but there are so many contributing factors that can lead to the development of high blood pressure. And so even with those with essential hypertension, often they're gonna have the elevation. Their manifestations will not show up during the initial stages, okay? Probably around good 6 months or to a year. Then there's going to what do you call this, appearance of those manifestations. Check on the message here. It's not one with my computer, but on my phone it started to check. Okay. Hello, can you hear me? I hope you can hear me. Hello, hello. I'm not quite sure if you're able to hear my lecture. Let me check on my end. Hang on a sec. Okay, good. All right, I was worried about that. You weren't able to hear my my voice. Okay. Yeah, it's been about or almost 10 minutes already. So good thing that you can hear me, guys. All right. Now, it's kind of low. Okay, let me try. How about that? Can you hear me better? All right. I think it's just my voice that a little bit low this time in the last few days. With the cold that I am having, it's just kind of limiting me. All right, how about now? Can you hear me better? Oh boy. All right, I hope so. Now, okay, good. Now, as far as the treatment goal here, when we are going to deal with a new patient, for example, a new client that is seeking for help, especially if they're probably manifesting the signs and symptoms of hypertension, right? Maybe they're starting to have like headaches, maybe they start to feel like nauseous or something like that. And we're the nurse taking care of this patient, and we're detecting that the patient's blood pressure is elevated, and we checked it several times already, different times. And so our treatment goal here, of course, with the medical provider's plan, the treatment goal is pretty much is to lower the blood pressure and also to prevent the organ damage. Okay, that is the primary goal, to lower the blood pressure and also to prevent the organ damage. And this is a chronic thing, and it will take a while to really establish that kind of like normalization of the blood pressure. And sometimes patient will not be probably they will have some reactions, or maybe they will have side effects that probably they don't like. And so it will take maybe a good few months before they can get used to the treatment. Now, let's remember, guys, that when we are treating the patient, when we are involved in the treatment, rather, of their hypertension, usually it will start with lifestyle changes, okay? Most often, the medical provider will not order the antihypertensive right away, okay? Most often, they're going to have to do some more testing, and they will include some modifications in the diet. They're going to recommend some lifestyle changes, such as inclusion of exercise. So those kind of things, they would try to do that first. And if there's no improvement in about 1 to 3 months, then usually they're going to incorporate the prescription, those antihypertensive medications. And there will be periodic visits that will be required in order to follow up if there's any worsening or there's improvement of the client's situation. Now, before we're going to have to go into the modalities of treatment, we need to know first that the body has its own system in order to regulate the blood pressure. And these are going to be affected in the long run. Maybe this will no longer work if there are unhealthy lifestyle changes or anything like that, then yeah, this will no longer be effective. But let's go back into the normal physiology first. Please take note that these are the mechanisms that are in our system. Hang on a sec. One is the arterial baroreceptor. So what are these? These are located in the carotid sinus, the aorta, and also the left ventricle. So they are going to control the blood pressure by altering the heart rate. And these baroreceptors can also cause vasoconstriction, or they can also cause vasodilation. Okay, so that is how these baroreceptors will be able to regulate the person's blood pressure, right? Now, there's also that system wherein, of course, we're talking about the kidneys right now. The kidneys are very crucial in the regulation of the body fluids. When they're working properly, they can retain the fluids if the person gets hypotensive, and they can also excrete excess fluids when the client becomes hypertensive. So as easy as that. The normally functioning kidneys are able to regulate the blood pressure with the hypovolemia or the hypervolemia state, or let's say if there is elevation of the sodium in the bloodstream. Now, another mechanism that can help in the regulation is the RAS. Remember about the renin-angiotensin-aldosterone system? Yes, I'm not going to elaborate this time. If you are not quite familiar with this one, I encourage you to go back into our lecture in the renal system concepts. I've extended the discussion about this system. And so when there is, let's say, a drop in the blood pressure, the RAS mechanism will be activated, which will in turn lead to the vasoconstriction and also the retention of the sodium and water, which will stabilize the person's blood pressure. Okay. Now, in another mechanism, we have the vascular autoregulation. So what is this? This is going to help the body to maintain a much more consistent levels of the tissue perfusion. Okay. All right. For those who just join us, I'm seeing new names here. Welcome to the classroom. All righty. Now, let's talk about the risk factors of both essential and secondary hypertension. You probably know about this, but again, I just want to reinforce of what you had learned in the past, so you'll be able to utilize these key concepts in the scenarios. Now, let's talk about the essential hypertension. So what is this? Well, this is going to comprise about 90 to 95% of the cases where the exact cause of the hypertension is not known, right? So essential hypertension comprise about 90% to about 95% of all cases. And when we're talking about essential hypertension, it will develop gradually for many years, and it will tend to manifest in the middle age or the older adults. Gradual progression and affecting more the middle age and older adults. Now, the exact mechanisms for the essential hypertension actually is very complex, and it's multifactorial, meaning that it can involve some changes or abnormalities in the blood vessels. It could be the regulation of the hormones, and there are so many things that are actually involved, including the kidney function as well. Now, part of the essential hypertension risk factors is the family history. This is huge, okay? So when a person has that genetic predisposition, this can influence the blood pressure regulation mechanisms. And if there is also a tendency for this person to take a whole lot of sodium in their diet, this can lead to fluid retention and also increase in the blood pressure. And with the type of foods that we are taking in, especially fast foods, those drinks, those preserved foods actually contain a lot of sodium, and this can really lead to the development of the essential hypertension. Now, physical inactivity is very common, guys. This can contribute to the development of weight gain and also poor cardiovascular health. And the same thing with obesity, which is pretty much going to be associated with the physical activity as well. Because the excess body weight can also put the strain into the heart and will also increase the blood pressure. Now, please take note, guys, that high alcohol consumption can also contribute to essential hypertension because the alcohol itself has a direct effect into the smooth muscle cells in the blood vessel. Okay? Direct effect into the blood vessels. Remember that the blood vessel has its own muscle layer, that smooth muscle that is going to squeeze or dilate, or it will relax as needed. And so if the person is prone to getting so much of the alcohol, it will be a lot harder for the heart to pump through the vasoconstricted vessels. And so it can elevate the patient's blood pressure. Now, another thing here is the race. And most in the literature, it's saying that the African American race has a higher tendency or higher risk to developing the essential hypertension. It's not quite known yet regarding the genetic factors, or maybe their higher prevalence of other risk factors, but they're quite known to have a higher tendency to develop this. Now, cigarette smoking is another one where it can also damage the blood vessels. The nicotine has that vasoconstrictive effect. And we also have the hyperlipidemia, of course. High cholesterol can contribute to atherosclerosis, plaque formation, and lead to hypertension. Now, stress. Yeah, stress. You're stressed preparing for the NCLEX. That's quite true. And also stress binging, eating a whole lot of junk foods. This can also elevate the blood pressure of the patient and causing much more release of that cortisol. Okay, are you familiar with this? Cortisol can promote the reabsorption of sodium, right? And plus water. And of course, the fat deposition, the also the formation of those fats, migration of those fats into the other parts of the body. This can really complicate things when you are in high stress level. Now, let's talk about the age as well. Why is aging going to be a huge factor? Well, when the person ages, the blood vessels will lose its elasticity with age. Okay? Decreased blood vessel elasticity. So they will become more rigid, not being flexible to the volume of blood running in the bloodstream. And so with a combination of both, this can definitely increase the blood pressures. Now, let's talk about the secondary hypertension here. Let me clear my screen. So secondary hypertension, what is this all about? This is referring to the high blood pressure that is caused by an identifiable underlying medical condition, or it could be caused by other medical issues, such as renal disease, which I have already mentioned in the renal concepts. So if their person develops any kind of kidney disorders, let's say renal failure, this can eventually disrupt the fluid and electrolyte balance and will lead it to hypertension. Now, another problem that is known to lead to secondary hypertension is Cushing's disease. And remember about the cortisol again. Increased cortisol production. This can increase the reabsorption of sodium and water, and also it can lead to accumulation of the fluids and lots of sodium in the bloodstream, and of course leading to that high blood pressure again. Now, another problem is the primary aldosteronism, wherein there is excess aldosterone and it doesn't fit. If there is primary aldosteronism, the aldosterone level secretion or the aldosterone level really is high. Okay. And remember that aldosterone and sodium are best friends, right? This can facilitate the reabsorption of lots of sodium ions in the kidneys. And so there will be hypernatremia, leading to hypertension. Now, another problem here is the pheochromocytoma, which is basically a tumor in the adrenal gland. Tumor growing in the adrenal gland. Hang on a sec. All right. In the adrenal gland. And this is going to increase the release of the catecholamines. All right. If there is that tumor growth in the adrenal gland, there will be increased secretion of catecholamines. What are these catecholamines? Do you remember about the norepinephrine and epinephrine? Catecholamines. And remember, once the catecholamines are released into the bloodstream, remember that this can lead to hypertension, right? Remember about the diagram that I showed you last time? For example, this is our receptor, and we have our norepinephrine and epinephrine as neurotransmitters, right? When they are released into the bloodstream, this can attach into the receptors. When these receptors are activated by the neurotransmitters, this can lead to the blood pressure elevation, okay? And that just not the blood pressure as well, it can also increase the heart rate, okay? So this pheochromocytoma will need to be treated with antihypertensive medications and also with the surgical removal of those diseased adrenal glands. Now, another problem that can contribute to secondary hypertension is the brain tumor or brain tumors, which can affect the brain's control center for the blood pressure regulation. And yeah, it can derange that function. Now, for those taking some medications, let's say steroids, prednisone, methylprednisolone, estrogen, or sympathomimetics like phenylephrine, okay? Phenylephrine, which is basically an ingredient in the cold preparations, decongestants. This can elevate the blood pressure as well, all right? And same thing with the pregnancy. If the patient ends up with a condition such as preeclampsia, where there is abnormal elevation of the blood pressure, and we know in pregnancy there is also an increased fluid circulating volume in their bloodstream. So they'll tend to have higher blood pressures in pregnancy, but on top of that, with the onset of preeclampsia, this will complicate things as well. Now let's move on into the next section of our discussion here, which is all about diagnostics and laboratory. But just to give you an idea that there is no laboratory test that exists in order to diagnose hypertension. Nothing. There is none. However, the laboratory findings that I'm going to talk about, they are only going to help in identifying the causes of the secondary hypertension. All right. Again, there is no laboratory test, there is no diagnostic test that ever existed to diagnose hypertension. However, these tests will be able to identify the causes of secondary hypertension and whether they are targeting a certain organ, okay? Now, let's talk about the BUN and the creatinine. When the person will have high blood pressure, most often the person probably has an elevated blood urea nitrogen, but not everyone, okay? I'm telling you that not everyone will have elevation of the BUN and the creatinine. This is going to be elevated for those people that may have a pre-existing renal disease, right? And so with the accumulation of these byproducts or waste products in the circulation, this can also lead to hypertension. Now, if there is elevation of the glucocorticoids in a case of the Cushing's disease, remember that the cortisol can also lead to hypernatremia. It can cause the retention of the sodium and also water. What else? Hyperglycemia. Blood glucose elevation can also be tested to check if maybe the person has a pre-existing diabetes mellitus, right? Or let's say if they have a pre-existing hypercholesterolemia. And so if the doctor will be able to correlate all these findings when we are looking into the labs, then definitely we can associate this to the ongoing comorbidity, right? Now, let's talk about the high blood sugar. Okay, what is really going on if there is elevation of the high blood or elevation of the blood sugar? So what's going to happen in hyperglycemia? It can lead into endothelial dysfunction. I'm talking about the inner lining of the blood vessel. It can damage this lining when there is hyperglycemia. It can also affect its ability to relax, dilation. It can also lead to an increasing resistance of the vessel and also elevation of the blood pressure. Okay. Now, another effect in the hyperglycemia, guys, is it can also promote the free radical production. Those oxidative stress will be increased. It can directly damage the blood vessels. And same thing with the inflammation. With high blood sugar, there's also going to be higher incidence of inflammation in the blood vessels. And over time, this can lead to stiffening and narrowing of the blood vessels. Stiffening and narrowing of the blood vessels. So it will increase the vascular resistance. Now, another thing that can happen if there is elevation of the blood sugar is the RAS activation. Okay. The hyperglycemia can activate this system by causing the blood vessel to be constricted. All right. And same thing with the insulin resistance. This can also stimulate the sympathetic nervous system and leading into the constriction of the blood vessels as well. So there's so many things that hyperglycemia can do to the blood vessels. Now, talking about the cholesterol elevation. This is huge, right? We know that there's that low density lipoprotein, the triglyceride, the high density lipoprotein. And so if there is abnormal ratios between the good and the bad cholesterol, this can lead to the deposition of the plaques into the blood vessels over time, can lead into the narrowing of the blood vessels, which will eventually cause higher readings, okay? Now, we'll talk about the diagnostic test here. And again, this is not going to really diagnose the primary hypertension. This will only identify the secondary, what else? It will identify the contributory factor, okay, or the comorbidities. All right. So the first one here is a 12-lead EKG, which is going to evaluate the cardiac function. It can show tall R waves. And this is going to signify that there is already a left ventricular hypertrophy. All right. And chest x-ray will also be utilized. And when the person has a significant cardiomegaly, it will be shown in the chest x-ray. So by the time that the person has this diagnostic test, they already have the pre-existing conditions going on. So let me just write that again. Cardiomegaly. All righty. Now let's move on to the next section of our discussion here. We will talk about the different clinical findings, those features that you will often see in a patient with hypertension. Again, most of the time they're going to be asymptomatic during the early stages, so probably they're not going to complain anything, right? But as soon as they're going to start manifesting, one of those signs will manifest headache, right? They're going to complain about probably occipital headache. And this is going to occur mostly in severe cases or sudden increase in the blood pressure. Severe high BP. Okay. And the reason, of course, is the increasing pressure, vasoconstriction, okay, in the brain. So they're going to end up with some nausea along with it. They're going to get dizzy because it can really disrupt the balance mechanisms in the inner ear, or it can affect the blood flow to the brain. So they're going to end up with kind of some kind of a lightheadedness, or let's say vertigo. So these are going to be associated with that. Now, in some cases, they're also probably going to be flushed face because the blood vessels in the face are now dilating, all right, leading to that reddened appearance. Now, there's also nosebleed, epistaxis, and this is going on because of the fragile blood vessels in the nose can be prone to the rupture when the blood pressure goes higher. And so they're going to end up with this episodic nosebleeds. They're also going to be tinnitus because the blood pressure can sometimes exacerbate or also increase the pressure within the blood vessels. Okay, this is going to be the buzzing sound in the ear. All right, of course, affecting the inner ear circulation here. Now, patients will also complain about the visual disturbances. There's going to be an effect on the small blood vessels in the eyes. Micro circulation in the eyes. I don't know if you have accompanied maybe an older family member, maybe your grandma or grandparents to the doctor's office. If they had high blood pressure, have you noticed that most often the medical provider will be checking their eyes with that ophthalmoscope to check if there's going to be retinal changes, blood vessels in the retina? Micro circulation in the eyes. So this will lead to some changes into the vision, right? The person will end up with blurring of vision, or it could be vision loss in some severe cases. Again, this is going to be checked using that ophthalmoscope to check for the retinal blood vessels. Or this is simply known as the fundoscopic exam. And this is to see if there's any minute bleeding or changes in the capillaries, in the the blood vessels in the eye, the small blood vessels. Now, in some cases, the person will probably end up with some chest pain. And the reason for that is because the hypertension can also lead to constriction of the coronary arteries. Constriction of coronary arteries. or simply because the heart is exhausted, it's doing a lot of work. I mean, if it's labored, right, because of the high blood pressure, it can really increase its own oxygen demand. O2 demand within the heart. So the heart itself will be deprived of the oxygen whenever the heart is pumping so hard in order to overcome the high blood pressure in the systemic circulation. And so it can lead to that chest pain. All right. And I can attest to that because I had that experience way back. And also, we're going to have to deal right now the different nursing actions, which are very important in the treatment of our patient with a high blood pressure. And so, first things first, we are going to really set that goal. Okay. We want to make sure that we have that conversation with the patient, make sure that the patient is able to understand that the goal here is to make sure we are reducing the blood pressure and also to mitigate organ damage. So this will help the patient to be more compliant with the treatment. Okay, so we are going to set the goal to reduce the blood pressure and make sure that we are mitigating possible organ damage. And most of the time we're referring to the kidneys, right? Or possibly the heart itself. Congestive heart failure, because CHF is one of the complications in the chronic uncontrolled hypertension. Now, another thing that we need to be doing in the baseline assessment here, guys, we're going to have to check for those symptoms that are present in our patient, or we're going to have to inquire about, investigate. Maybe they have some manifestations that they already have and they're just kind of ignoring it. Okay, so we want to make sure that we have that in-depth conversation to evaluate for these manifestations in order for them to tell us that this has been going on, and maybe while we are treating them, that they can report that there's no resolution to their issue. All right. Now, another thing that we'll be doing in the assessment phase is to check their blood pressure initially and then monitor it. Okay. So what are we going to do here? We're going to have to check their BP, or the blood pressure, in both arms. And we are doing this not just once, but this will be done in 2 different times. In other settings, probably it will require 3 different readings. And we want to make sure that we are also checking the patient when they are in a very relaxed position. Maybe the medical provider would want us to check the blood pressure when the patient is lying supine, or maybe sitting, or maybe standing. And it depends into their prescription, right? In order to really, for us to capture any of these readings, and it will also help us detect any kind of orthostatic changes, and this will really help in guiding the treatment. Now, another thing that we need to keep in mind during the assessment is the historical comparison of the blood pressures. Okay, so what does it mean by that? What does this mean? Okay, so definitely we're going to have to check the patient's current blood pressure, right? We're going to have to compare it with the previous records. And we are going to track these blood pressure trends over time. And again, this will guide the treatment. Maybe there will be some adjustment in the medications, or maybe another modification, the patient's lifestyle will be incorporated. Now, another thing that will be needed in the baseline assessment is to identify the patient's family history, because this is very important. Remember that familial predisposition really will influence the cardiovascular risk. And so this is going to be a non-modifiable factor, right? Which is kind of sucks, but this will really tailor the treatment plan in order that we can create some preventive measures in the treatment. Non-modifiable factors, okay? Now, we're also going to take a look into the patient's medications. We're going to have to look into the history of what prescriptions they are using, the current and also the past regimens, so that we can properly assess if they have been adherent, if they have been compliant with the medications, maybe with the previous medical professional or medical providers, if they probably have some kind of like adverse reaction to that particular medication, or maybe potential interactions with the other medication. So this is very important. Make sure that we will be reviewing first what? Medication compliance. Because maybe this patient has been going to different medical providers, right? Maybe they're only going to stick with that provider for maybe 2 months. And then the next 4 months, they're going to have to look for another doctor. And again, they're not being compliant with a medication order. They're going to have to go into another medical doctor. And so this is something that will be easily tracked when we are going into this section of medication review. This will also help us evaluate for the efficacy of the medication regimen. Maybe the patient is no longer responsive to the ACE inhibitors. Maybe they're no longer responsive to the ARBs, the angiotensin receptor blockers. Maybe they're going to need another type of antihypertensive medication. Now, another thing that we need to do here is the weight measurement. This is very important, guys, because this can give us better insight into the metabolic health of our patient. So if there is a significant weight increase from the previous months, maybe they probably develop some kind of metabolic syndrome. This will really help in the treatment, guide the recommendations, let's say, for example, dietary and lifestyle interventions that will help manage their blood pressure. Now, another thing that we need to do in the baseline assessment is to evaluate or assess their diet, okay? So are they taking in a lot of preserved foods, maybe canned goods? These are things that can really develop into uncontrolled hypertension, okay? The use of those drinks. What else? Use of caffeine. There are so many preparations, beverages that contain a lot of caffeine nowadays. And so we want to make sure that we have those information so our treatment plan is guided. Now, another thing that we need to assess here is the eye status, the vision status of our patient. So we're going to have to check for any signs of retinal damage. Let me write that down. Check retinal damage. And I already mentioned this a little bit earlier ago about that fundoscopic exam to see for this chronic changes inside the eyes, okay? So it will identify the hypertensive retinopathy. And again, this will also prompt the medical provider to include timely interventions to prevent permanent vision loss, okay? Because this can really lead to a permanent damage. Now, we're also going to have to do that extensive cardiovascular assessment. So what is included in this assessment? We're going to have to check for any signs of what? Like the JVD, the jugular venous distension. Let me erase that. My V doesn't appear good. JVD, which is going to be associated with right-sided heart failure. Right-sided heart failure. Or maybe increase in heart rate. That's another one. Or it could be dysrhythmias. These are things that we need to include in our baseline assessment. And that is why an EKG is usually going to be done if the doctor is suspecting that maybe this patient's high blood pressure is caused by something else, maybe a cardiovascular issue. secondary type of hypertension. Now, there's also a need for us to review the radiographic results. So we'll take a look into the chest X-ray of the patient. I'm not telling you that you're going to be diagnosing, right? But definitely it's very important for us to know to relate to the diagnostic test, especially if there is some sort of cardiac enlargement, cardiomegaly. This is indicating cardiac stress over time, chronic cardiac stress. And this is again because of the systemic vascular resistance that has been going on for several years. Now, another assessment that we need to complete will be the neurological assessment. This is important, guys. And so if the person probably will have some kind of a stroke, let's say cognitive impairment, yeah, this can help out in identifying these complications. Stroke, cognitive impairment. So it's quite important for us to know that we're not just talking about the readings in the blood pressure, but we're also going beyond looking into the neurofunction. Now, another thing is checking into the patient's renal function. We have to look into their studies, lab tests, maybe diagnostic tests in order for us to monitor the impairment in the kidneys. All right. So I hope that you're able to capture those important concepts just in the assessment phase. Now let's go into the non-pharmacologic interventions for the hypertension. So non-pharmacologic interventions will include the weight management. This is very important. Make sure that this is going to be set with you and the patient, that there will be realistic goal setting. As we know that if there is significant reduction in the weight, this will really reduce reduction in the weight. This will reduce cardiovascular strain, especially the heart. Weight loss is going to be beneficial. Now, another is sodium restriction. Why is sodium reduction is important? As we know that whenever there is hypernatremia, this can also lead to retention of water. Where the sodium is, water will follow. And so sodium restriction probably will be like about 2 grams of sodium per day. 2 grams of sodium per day. This is kind of like I think would be more acceptable in the general population, and this will decrease the incidence of the high blood pressure. Another thing is that the person or the patient will need to have a moderate intake of alcohol and also the caffeine. Okay, remember that the alcohol has a direct effect into the blood pressure. This can cause the vasoconstrictor, and the same thing with the caffeine. Those energy drinks that people will often use before they engage in, let's say, a physical activity and exercise, or before they go to the gym, they usually will end up with taking a lot of caffeine, or maybe you guys studying way too much, even late in the evening or early morning, taking way too much caffeine. So please do that in moderation. Don't overdo it. You will get exhausted. Regular exercise, guys, is very important. You got to make sure that the patient understand the benefit about a consistent exercise, because this can also strengthen the heart and also improve the circulation. Now, another thing is smoking cessation. This is quite huge, guys. Smoking cessation along with a moderate intake of caffeine and alcohol, because avoiding smoking will really decrease the cardiovascular tone, or let's say the vasoconstriction. Now, another is stress management techniques. It could be biofeedback therapy, relaxation methods, those kind of things. This can really reduce the stress stress hormones rather, I would say reduce stress hormone, the cortisol. Probably right now, guys, your stress hormone is so elevated if you're so stressed preparing for the exam, right? Cortisol level can do that. Um, Medication review, another important factor in the treatment of hypertension. We are going to report to the medical provider those possible medications that can contribute to hypertension. HTNs. Meds contributing to hypertension. Okay. So make sure that you are reporting this right away if the patient really has that abrupt elevation of their blood pressure. Okay. Or even if not abrupt blood pressure elevation. So yeah, you can communicate that to them. Now, this time we're going to talk about the different pharmacological interventions. I'm simply just putting them in a table right now in order to capture the different drug classifications. There's so many antihypertensives, but we will focus into the most commonly used antihypertensive medications and focusing into the nursing applications as well. So part of the antihypertensive regimen, usually the medical provider will start prescribing diuretics. And most of the times it can include the thiazide diuretics. Okay. Have you helped somebody, maybe a family member that are diagnosed for the first time? Have you helped them out with their clinic visit? For me, when I was first diagnosed with hypertension, the medical provider really wanted me to try the diuretic, the thiazide, and I know what the diuretic is, and I don't want to take it, especially that it would make me go to the bathroom, and this would be trouble when I'm working. And so, yeah, he ended up ordering a different kind of classification. But the reason that we are including this discussion, because with the thiazides, this is going to help in excretion of what? The sodium, right? Excretion of sodium and water. The same thing with the loop diuretic, okay? So this will be helpful in managing the high blood pressure by excreting excess water, excess sodium. However, guys, please take note that these thiazides, the loop potassium-sparing diuretics, also have its own side effects. And so this is probably where you're going to be tested in the NCLEX. Do you know the side effects that you need to teach to your patient so you can intervene those? So what are these things? And I'll be talking a lot more about making sure that they do their monitoring of their blood pressure. Well, in the acute care setting, well, we're going to be monitoring their blood pressure frequently. We're going to have to look into the laboratory results daily to check if there's probably hypernatremia or maybe a lack of the sodium. And another thing is we're going to have to check for any signs of electrolyte imbalances. This is very important, as we know that if there's any imbalance, this could potentially harm the heart. It can lead to arrhythmias, which could also influence the other organs in the body. Now, also take note, guys, that if the patient will be taking the loop diuretics, let's say Lasix, or let's say thiazides, this can lead to hypokalemia, a drop in the potassium level. Please take note, guys, when they take loop diuretics such as furosemide or thiazides, they can develop hypokalemia. All right. So when we are teaching them, make sure that they are taking in or increase their intake of potassium-rich foods. All right. If they are taking the loop diuretic or the thiazide diuretic. Now, another thing here is when they are taking the thiazide, and this is what I noticed more in the elderly population. they're going to end up with hyponatremia, low sodium levels. This is not good because, well, of course, if they're going to be hyponatremic, what do you think could happen? It can affect their neurological function. They can start to get confused. In the severe cases, it can lead to seizures as well. So it's very important that when they are taking the thiazide diuretic, they need to have periodic check in their sodium level in order to prevent dangerous levels, low levels of the sodium. Okay, so make sure that we are checking sodium levels periodically. And it's no fun, guys. When they get confused, it's no fun. They get so combative, they will not be able to understand what you're telling them. They will be resistant if they're going to get confused. All right, microphone on. Now let's talk about the effect of the loop diuretic. Remember that the loop diuretic will remove the fluid. This will inhibit the sodium reabsorption in the kidney tubules. Okay, in the kidneys. So that is the general effect of these diuretics. Now let's move on into the next classification here. We have the calcium channel blockers. Oh, before we go to that, I forgot. There's another one over here. So for example, if they are taking the potassium sparing diuretic. So what is this potassium sparing diuretic? An example about this is the aldactone, or simply known as the spironolactone. Spironolactone. So these medications are known to conserve what? Potassium. Conserve potassium in the kidneys. So what the person will end up is that they're going to be prone to developing hyperkalemia if they're not watching their diet. This can lead to hyperkalemia. And so they should be taught about limiting the intake of potassium-rich foods and also avoiding those, what? Salt substitutes, those seasonings, okay? Salt substitutes, because they contain a lot of potassium in it. And so the patient should be advised to avoiding this salt substitute in their diet. All right. Let me move forward to the next medication group. These are your CCBs, or the calcium channel blockers. And I've mentioned about them in the previous topic, especially with the treatment of the pulmonary hypertension. Calcium channel blockers will be helpful. So we have the following examples here: the verapamil, the amlodipine, the diltiazem, and most of these medications that end with the suffix pin, they are the calcium channel blockers, right? Not all though, but some of those medications that end with the IPINE are calcium channel blocker. So again, what is the effect of the calcium channel blocker? So let me just draw this one right here. Supposing this is the blood vessel. And then this is our cell. If there is entry of the calcium ions into the cell, it can allow that calcium ions to enter, and it can increase the excitability of the cell. And not just the body cells or the tissue cells, but also the cells inside the blood vessel itself. And so the role here of the calcium channel blocker is really to prevent the entry of the calcium into the cell. And when that happens, if there is inhibition, the patient's smooth muscle, there will be an increase in the relaxation of the blood vessels. And so this can cause a normal BP or also a reduction in the heart rate, normalization, I should say. Now, let's talk about the nursing management involved in the administration of the calcium channel blockers. There's a few things here that you need to be reminded about. We're going to make sure that we are monitoring the patient's blood pressure, the pulse rate, and you need to be cautious for those patients that have heart failure, because in the heart failure, remember that their contractility, heart failure patient, there is decreased ventricular contractility. So we don't want to really administer this medication if in case there is worsening heart failure. Again, the calcium channel blockers can decrease the ventricular contractility. So if the patient has worsening heart failure, it is not advisable for us to administer this medication because it can cause that decompensated heart failure. It can lead to worsening of the heart failure. Now, another thing is that we're going to have to make sure, include in the education, guys, about the side effects. What are these side effects? Including constipation. That is a very common side effect of the calcium channel blockers. We will be recommending an increased intake of fiber in the diet, and we're also going to help them to monitor their pulse rate at home just by using their radial pulse, or maybe if they have a monitor at home, if there's some irregularity of their heart rate. This is very important for us to educate that they need to report these findings when they are dealing this kind of issue, or when they are actively participating in self-medication. Okay. And another thing, guys, that you need to emphasize is to teach them to avoid grapefruit. Why? Because the calcium channel blockers can actually inhibit the enzyme, or actually the grapefruit. The grapefruit is known to inhibit the enzyme What's the name of the enzyme? That's the CYP34 or 30A4. So this is the name of the enzyme that will be inhibited by the intake of the grapefruit. Okay. Normally, the enzyme CYP3A4, this is known to, let me just write it here so you don't get confused. CYP3A4. Normally, it will break down medications, including some calcium channel blockers. Okay. Normally breaks down medications, including CCB. All right. Now, if the grapefruit is being taken by the patient, if they did not know that it's not supposed to be taken while they are taking the, or if they, while they are under the pharmacological treatment of CCB, this will cause the elevation of the calcium channel blocker levels in the bloodstream. Okay, again, if the person will keep taking the grapefruit while the patient takes the calcium channel blockers, this can lead to increases calcium channel blocker levels in the bloodstream. So this will be kind of like toxic effect to the body. So what do you think, do you expect happening to this patient if they're gonna be taking the grapefruit? Well, The side effects here will be low blood pressure. Low blood pressure, that's one. Okay. Another is dizziness. The patient will also have some other reactions. So I'm just emphasizing here the two main manifestations when the patient takes CCB along with grapefruit. Okay. So it's very important that they avoid taking any grapefruit while taking CCB. All right, so I hope that you're able to capture that explanation. Let's move forward with the next classification of medications. We are talking about ACE inhibitor this time, which is very popular. I'm taking that medication. The Pril medications. ACE inhibitors. Remember about its effect? It will block, or it blocks the conversion of angiotensin 1 to angiotensin 2. That is the mechanism of action for the ACE inhibitors. Remember, guys, that the angiotensin 2 is a potent vasoconstrictor. So when that happens, it can lead to high BP, right? Now, another effect of the angiotensin 2 is the secretion of aldosterone by the adrenal cortex. When there is increased aldosterone release, it can lead to what? Sodium reabsorption and also water, right? And so it can lead to increased BP as well. Now, the reason why the lisinopril or the ACE inhibitors are effective in treating the high blood pressure, because it will block the conversion. None of this will happen if the person takes the ACE inhibitor. Again, none of this will occur, right? There is no conversion when there is ACE inhibitors taken. So with ACE inhibitors, let me just write that down. With ACE inhibitors, no conversion of angiotensin 1 into angiotensin 2. So that is the easiest explanation why ACE inhibitors are effective in the treatment of some hypertensive disorders. Okay, not everyone will respond to this, but I'm telling you that it can be effective to other forms of hypertension, I should say. Now, talking about the ACE inhibitors here, we'll move forward into the nursing applications. We're going to have to monitor the patient's blood pressure when they are admitted to the hospital, when they're being treated with the ACE inhibitors. We're also going to monitor for any manifestations of heart failure. If they're going to end up with worsening heart failure, that is also going to be monitored. We're going to have to teach the patient to avoid taking in potassium-rich foods, because remember that the ACE inhibitors can what? Suppress aldosterone secretion. It suppresses aldosterone secretions. And remember, guys, what is the main controller? What is the regulator for the potassium in the body? Remember that aldosterone is the regulator. And so if there is no longer a regulator for the potassium, then they're going to end up with hyperkalemia. And that is why we have to teach our patient to avoid intake of potassium-rich foods, because they're going to be prone to developing hyperkalemia. So make sure that we're also monitoring their potassium levels. They need to have that, okay? especially if they have other comorbidities, let's say renal failure, wherein there are going to be difficulty in getting rid of the excess potassium in their body. This is very important. Okay, make sure that they're avoiding intake of way excessive potassium food items. Let's get to the next. Let me see. Next implication. We're going to have to instruct the patient to report persistent cough. And we are talking about the dry cough. I mentioned this yesterday. Dry cough is persistent when they are taking enalapril or the ACE inhibitors. And the reason for that is because the accumulation of the bradykinin in the bloodstream. It can what? Irritate the receptors. That's why they're going to end up with that dry, persistent cough. This can also lead to some edema and angioedema, which is an adverse effect of ACE inhibitors, right? Angioedema, which is that enlargement, swelling of the patient's tongue, which can potentially obstruct the airway. So this is a complication of taking ACE inhibitors. All right. Now let's move forward to the next classification, guys. Aside from the ACE inhibitors, we have the ARBs, or the angiotensin receptor blockers. Angiotensin receptor blockers. We have the suffixes here, the sartans, losartan, valsartan. So the patient taking this medication will also be monitored for their blood pressure. Potentially, they can also develop the angioedema and signs and symptoms of heart failure. We're going to have to also teach them to avoid intake of potassium-rich foods. This is also important in order to prevent that elevation in their potassium content. And also make sure that we are monitoring their potassium levels in order that the medical provider will be able to tell them, hey, I don't think that you're going to need to take in a lot of the potassium-rich foods. We need to modify your diet, or we're going to end up probably decreasing your medication dose. So that's probably the plan of care. Now let's move forward to the next medication group, and this is going to be about the beta blockers, which is very common in the treatment of hypertension. So the beta blockers are popularly used, such as the metoprolol, those olols, okay? The olols. Now, you got to be careful here, guys, when you're administering the non-selective olol, non-selective beta blocker. But before we go to do that, it's our job to monitor the patient's blood pressure and pulse rate, because the medication can decrease both BP. Of course, that's the therapeutic effect, right? But also it can reduce the heart rate. So for those patients that may have issues with heart block, you have to be careful. Or let's say for those patients that may have a history of bradycardia, you gotta inform the medical provider, hey, our patient now is more bradycardic than previous. Okay, so let's say, for example, the patient is taking the new medication metoprolol, and probably during the first 2 nights their heart rate probably is in the low 60s beats per minute, and in the succeeding days maybe their heart rate now is a lot lower, maybe in the mid 50s or high 50s, or maybe in the low 50s. You really need to emphasize this to your medical provider. Our patient now is more bradycardic than before. Or maybe in the telemetry, the technician probably would be calling your phone more often now because maybe the patient is developing more of the heart blocks. So you got to be careful in the administration of the beta blockers, because it can decrease the heart rate of the patient as well. Now, another thing is you're going to have to educate the patient to report any of these manifestations: fatigue, weakness, sexual dysfunction. I'm talking about impotence. make sure that if they feel like they are developing these side effects, that they do not abruptly discontinue the medication. So make sure that they consult first the medical provider before they discontinue taking the drug. All right. Now, another consideration here when you are dealing with a patient that has hypertension, or let's say, for example, if they have some chronic airway limitation or maybe asthma. Well, beta blocker and asthma will not work together, okay? Beta blocker. Not good. This can lead to bronchospasm. Okay, I'm talking in general here because there is what we call as cardioselective beta blocker. Good morning. Cardioselective beta blocker. There are also beta blockers that are non-selective, such as the propranolol. Okay, let me put here propranolol or the Inderal. So when we're talking about the non-selective beta blocker, it can reduce the blood pressure. It can stimulate those receptors that will cause a drop or that will cause a vasodilation, but also it can trigger the receptors in the lungs. Okay, so the non-selective beta blockers can trigger bronchospasm. So make sure you obtain thorough history from your patient if they have any asthma. Okay, because if the patient receives the non-selective beta blocker, they can develop bronchospasm. Okay, now guys, I'm just emphasizing this right now. Even the cardioselective beta blockers don't usually cause bronchospasm, but they can if the dose is higher. They can also lead to bronchospasm. So you got to be careful, especially if there's some adjustments in the cardioselective beta blocker dose, because it can also result to the bronchospasm. Okay, but most often what is emphasized in the textbook is that, especially pharmacology, is that we are gonna avoid the use of the non-selective beta blocker in a patient with asthma because they are known to really cause the bronchospasm. However, even though it is safe to use or administer the cardioselective beta blocker in an asthmatic patient, but then they can still cause bronchospasm if the dose will be higher, okay? Or if there's probably a need to adjust the beta blocker medication. So it can also lead to the bronchospasm. All righty. I hope that you're able to follow with those concept. So we have here, let me just put here the name of the cardioselective, the atenolol, and then we have the non-selective, which is the propranolol. So it will cause bronchospasm. All right. Moving into the next classification, we have the centrally acting agonist. So it's represented by the clonidine, the methyl-dopa. It has a very unique action in controlling the blood pressure. It will cause sedation. It will cause the vasodilation by decreasing sympathetic nervous system stimulation or decrease outflow from the sympathetic nervous system. And so they're going to end up being kind of like sedate, sleepy, drowsy. There's also going to be a common orthostatic hypotension. Okay, so you got to be careful, especially during the initial days when they are taking this medication, especially the elderly people. They will tend to have falls because of the orthostatic hypotension. Another is impotence for men. This is a common complaint. And so let them know that they're going to experience this once they take this medication. Now, we'll be talking about the last classification that is commonly used, and this is on the alpha adrenergic agonists. These are your prazosin and doxazosin. And we're going to have to monitor the patient's blood pressure as well, because it can really cause hypotension. Even though we really want to reduce the blood pressure, we don't want them to really have a much lower blood pressure. We just want to reduce that, but not way too much. So it's good to keep an eye their blood pressure trends. We're also going to make sure that we are educating our patient to instruct them to get up slowly, rise slowly upon rising in the morning, to prevent the orthostatic hypotension, and to be cautious when they are driving because of the what? The hypotensive effect. It can get them a little bit dizzy. There's going to be some dizziness. All right, enough with those pharmacological treatment. We're going to talk about the complication here, which is pretty much the hypertensive crisis. But before we're going to shift into that discussion, we are inviting you guys to join our course at www.stancoast.NCLEX-coaching.com. We are offering that NCLEX program, which you can access for 6 months, and you will have access to our on-demand lectures and also animated videos that you can use 24/7, of course. And we have 200 plus NGN questions, and we have study guides as well that will be provided, plus the mock exams on top of the test questions that we're offering. So we really want you to be more confident before taking the test. So kindly check out our website. And also, if you need some more information, click the description below or check the description below. Now let's go into the complication right now. So what I have said here is that the patient might develop the hypertensive crisis. This is common. And more often than not, that I have dealt with way so many hypertensive patients in my life, that you will get so busy in your shift, instead that you're going to take care of 5 patients in the medical surgical setting. Sometimes you're going to be pulled into taking care, spending more time into this patient with a hypertensive crisis during the first 4 hours of your shift. And yeah, that's just the reality, especially when there is a huge change in their condition, right? And this hypertensive crisis can happen when the patients fail to be compliant in their prescribed medication regimen. So one of the reasons why they do have this is because of poor compliance to the medication regimen. Maybe they don't like the side effects of the drug. That's why they decide, hey, I just don't want to take it today. I'll take it tomorrow, even though they're supposed to be taking it daily. Yeah, patients are like that. They are non-compliant. They'll do their own regimen. And so we have to really recognize the causes why they develop hypertensive crisis. Now, what are the manifestations if they're going to end up with this situation? Well, most of the time they're going to end up with a severe headache. There's also going to be a high blood pressure reading, greater than 180 in the systolic or greater than 120 diastolic blood pressure. I've seen patients greater than 250 systolic. It's just going to scare you the hell out of you if you're going to end up looking into your blood pressure machine and you're going to get like a 250. Yeah, it will excite you for that moment, right? But you really need to treat your patient immediately once you get that very abnormal assessment. And so again, their blood pressure can skyrocket with a minimum of about more than 180 mmHg for the systolic, greater than 120 for the diastolic. Along with that, they can also manifest some blurring of the vision. Maybe they're going to be dizzy. Maybe there will be some confusion because of the poor oxygenation or blood supply to the brain. And at some point, they're going to end up with the nosebleeds. Epistaxis, because of the rupture of those minute blood vessels in the nose. And what are we going to do here in order to intervene this patient with the hypertensive crisis? Well, we're going to need the high-powered antihypertensive medications this time. And so one of those medication is the administration of the nitroprazide, or it could be the nicardipine, or the labetalol. So what is the nitroprazide? This is a very powerful vasodilator. Nicardipine is a calcium channel blocker. And then we have the labetalol, which is actually a what? A beta blocker, non-selective beta blocker. I didn't mean that we have to give all three. No, these are just examples of medications that will be ordered when the patient has hypertensive crisis. So either one of the three, all right? And so what is the effect of the nitroprazide? The action of the nitroprazide really is going to what? It can work as a prodrug. The nitroprazide acts as a prodrug, and it can react with so many proteins, including the red blood cells, and it will release the nitric oxide. Nitric oxide. Now, this is big deal, guys. When you hear about nitric oxide, or NO, this will now bind with the smooth muscles of the blood vessels. With smooth muscles of the blood vessels. So it can now result into the relaxation of the blood vessel, vasodilation. So that is the end effect of the nitroprazide. Okay? Nitric oxide can bind to the smooth muscles of the blood vessel, which can result into the vasodilation. So it's very effective in treating hypertensive crisis. Now let's move on to the next medication, the calcium channel blocker, nicardipine. All right, nicardipine can also be effective. Let me just change that to a pen. Now, the nicardipine belongs to the drug class CCB, right? So again, it will inhibit the entry of the calcium ions into the vascular smooth muscle cells, which can also lead to the vasodilation. Vasodilation, it will prevent entry of calcium ions into the blood vessel cells. Oh. Yeah, the blood vessels have its own cells. And so that's effective because it will prevent that entry. It will lead to vasodilation. Now, the beta blocker right here. Again, I'm talking about the labetalol, which is the non-selective. You got to be careful here, guys. This is going to be contraindicated in patients with asthma. Patients with asthma. We don't want to give that because it can lead to bronchospasm. Now, once we have started these medications, the nitroprazide maybe, or the nicardipine, or the labetalol, we're going to have to check their blood pressure after we have done our baseline blood pressure monitoring, also the heart rate, also the cardiac rhythm. We want to make sure that we are doing this frequently every 5 to 15 minutes in order to capture any changes, worsening, or maybe improvement. We're going to have to assess their neurostatus, because if in case the patient will not respond to the potent vasodilators, then it can potentially lead to the stroke, right? So we want to make sure that we are checking our patients every now and then for any neuroscience. Now, another is to monitor their cardiac rhythm on a continuous cardiac monitor. Whoops. Again, this will probably take a while before the patient will have normalization or stabilization of their blood pressure. And most of the time, guys, this is more appropriate. The hypertensive crisis probably can be done, or the treatment of the hypertensive crisis can be done in the med-surg setting. But if this is going to really require more of a one-to-one care for your entire shift, then that is not good. Okay, as I've said earlier, probably if your patient turned out to have a hypertensive crisis, and let's say in a span of 2-3 hours and there is no improvement, it's time to ship this patient out of the med-surg. Talk to the doctor that it's no longer applicable, it's no longer safe for you to take care of this patient in the med-surg setting. Make sure this patient is going to be taken care of by the ICU nurse, or maybe the progressive care unit or telemetry, because they have lesser patient, and of course they'll be able to manage this patient much better because of their higher level in their skills, right? And so hypertensive crisis, as like I have said, can be managed in the med-surg. However, if this is really gonna consume your time and you are neglecting the other patients, then it's time for you to talk to the doctor. Hey, it's no longer safe for me to take care of this patient in this med-surg. I recommend that you're going to transfer this patient to ICU, or let's say higher level of care. All right, moving on. We're going to talk about the questions right now. Question number 1. How should the nurse measure a new patient's baseline BP in a hypertension clinic? The question is, how should the nurse measure a new patient's baseline blood pressure in a hypertension clinic? Is it A, deflate the blood pressure cuff at 5 to 10 mmHg per second, or B, seat the patient with feet flat on the floor, C, have the patient lie down for the measurement, or D, take two blood pressure readings in the dominant arm and average them? Okay. We are on the test mode right now. All right. So, what would be your action here? Are you going to deflate the blood pressure cuff in 5 to 10 millimeter mercury per second when you're checking the blood pressure? Or are you going to seat the patient with feet flat on the floor? Or are you going to have the patient lie down for the measurement? Or are you going to take 2 blood pressure readings in the dominant arm and average them? Okay, I'm seeing a lot of letter D's right now. I'm seeing a lot of letter D's. I'm seeing letter C. Have the patient lie down for the measurement. Okay, what would be the best technique in checking the patient's baseline blood pressure? All right, let's go through the rationales right now. If you had answered letter A, okay, letter A, deflating the cuff at a rate of 5 to 10 mmHg per second, this is incorrect. All right, because when you are deflating the blood pressure cuff of the patient, the rate should be what? It should be at 2 to 3 mmHg per second. Guys, you are releasing the air way too fast if you are deflating it at 5 to 10 millimeters per second. That's way too fast. So this patient might end up with a false low measurement, okay, if we are deflating the cuff way too fast. There is that rapid release of the pressure, okay? Now, let me remove that. What about letter B? Seat the patient with the feet flat on the floor. What do you think about that action? Well, you want to make sure that your patient is seated, okay? And make sure that their feet is planted on the floor, flat, to ensure proper circulation and stable position, okay? So make sure you do this. This is a correct answer. Answer is letter A. Oh, letter B rather. Sorry. Letter B. You make sure that the patient is sitting with the feet flat on the floor. Okay, let's take a look into the other options here. Letter C. Have the patient lie down for the measurement. Is it really required to put the patient in a supine position to check the initial blood pressure readings? No, not really. It's not a requirement. C, supine, not required. What about letter D? Take 2 blood pressure readings in the dominant arm and average them. What makes this option wrong is that you're not supposed to average. No way, Jose. Okay. And also, reading on the dominant arm, no. We're supposed to be checking the blood pressure in both arms. Okay. And this is not going to be consecutive like one after the next. The reading should be done in a different time or at a different time. So let me clear this. Letter D is wrong because you're not supposed to average the readings. Okay? Whoops. This is a fundamentals of nursing question, guys, and you probably will be killed by this test question. And so, checking the blood pressure, no averaging, should be done in both arms. You have to compare the readings in both arms, not just the dominant. And the readings just doesn't happen in one visit, okay? Readings will be done again. I'll just put here, readings done at separate dates, okay? Different dates. So if you are just checking the patient's blood pressure, let's say 30 minutes after the first reading, that's not going to be a reliable reliable measurement of the patient's hypertension. Most of the time, you're going to have to ask them, or the doctor will arrange another appointment to make sure that we're going to capture a fresh value in their blood pressure the next day, or maybe another appointment will be set up for them. Okay, so not just checking the blood pressure in the dominant arm, and we're not supposed to average them. All right. So the best answer here is letter C. Have or seat the patient with the feet flat on the floor. This is the safest and the most correct answer for this question. All right. Guys, be careful in your test items, guys, especially fundamentals of nursing. This is where we are mostly get killed. Okay. Yeah, the assessment. And I really recommend you guys go back into the nursing assessment textbooks, because this is where you're going to be asked more often. Reduction of risk potentials. I highly encourage you on doing that. I've focused on the nursing assessment. Okay. Moving on to the next question, guys. A 49-year-old male patient with severe hypertension has increased heart workload due to what factor? The question states, a 49-year-old male patient with severe hypertension has increased heart workload due to what factor? Is it A, higher afterload, B, increased cardiac output, C, heart overload, D, increased preload? Let me reread. A 49-year-old male patient with severe hypertension has increased heart workload due to what factor? Is it A, higher afterload, D, increased cardiac output, C, heart overload? This is such a tongue twister. D, increased preload. Your answers, please. Okay. All right. While I'm waiting for your answers right now, let me just reveal the correct answer. The correct answer here is letter A. Why? Higher afterload. Okay. So let's go back to that avocado heart again. Okay. It said here, severe hypertension, increased heart workload. We're talking about the workload of the ventricle. Most often, this is the hardest working chamber in the heart. Left ventricle. Most hard worker. And the reason for that, it's because when the patient, so this is aorta, right? Okay, so this is the aorta. Okay, aorta. But let me just extend the blood vessels right here. So for example, if there is hypertension, I really want to make sure that you understand about the afterload, guys. This is very basic. So you need to understand this so you will not be able to get confused when you're answering such question. When there is hypertension, the resistance in the systemic circulation is so high. Increase in the resistance. The blood vessel lumen is now narrowed, right? Again, there is high resistance in the systemic circulation when there is hypertension because the blood vessel lumen is narrowed. Well, if this is going to be chronic, if there is hypertension, if it's uncontrolled, over time, it can strain the left ventricle, okay? It can cause the heart to work harder, right? And the question is asking, it said, a 49-year-old male patient with severe hypertension has increased heart workload due to what factor? Okay, that is the afterload. So what is the afterload, basically? The afterload simply means the resistance. This is the resistance the left ventricle must overcome. The left ventricle must overcome. Okay? To eject the blood. All right. So it's just like when you are, for example, let me think of like an analogy here. Okay, I think I've made up my mind right now. Have you tried like watering your plants using that regular garden hose? When you are watering your plants, and let's say, for example, your hose is kinked, okay? When your hose is kinked, do you notice that when you are actually stepping onto the water hose, and when you are kind of like watering your plants, the stream of the water is lesser, but the pressure is so high. Okay. And so if this is not going to be, if the kink is not going to be resolved, it can create the pressure inside the faucet. It can destroy the valve if you're not going to unkink the tubing. Okay, so the same will apply to the heart. If the blood pressure, that is the chronic blood pressure, is increased, if there is that uncontrolled hypertension, this will cause the heart to work harder in pumping the blood out from the left ventricle into the circulation. Okay, so this is what we call as the afterload. All right, are you understanding this right now, guys? I just want to make sure that you understood the concept about the afterload. This is the amount, or this is the resistance that the left ventricle must overcome in order for it to effectively pump the blood from the left side of the heart. Okay? Now let's move forward to letter B. What is B? Increased cardiac output. Well, the cardiac output by definition, cardiac output. The cardiac output is the amount of blood which is ejected by the heart every minute. Okay? The cardiac output is the amount of blood that is going to be pumped by the ventricles every minute. Not just the left ventricle, but also the right ventricle. Now, what is the normal cardiac output? If I may ask you, what is the normal cardiac output? Well, in the adult, the normal cardiac output can vary. It can range from, let's say, 4 liters to 6 liters per minute. Imagine that, per minute. 4,000 mLs to 6,000 mLs per minute. That is the amount of blood that the ventricles are pumping every minute. That's a lot, guys. So if you are a huge water drinker using that big Aquafina bottle, there are like about four of those, or 6 bottles of those Aquafina bottles that actually is being pumped by your heart every minute. So that's a lot, guys, every minute. Now, let's rationalize why it's not cardiac output this time. This is not gonna the cardiac output basically is going to be the amount of blood that will be pumped, okay? And this is going to be influenced by the strength or the contractility of the ventricles. So like I have said yesterday in our discussion in congestive heart failure, remember that we talked about the ejection fraction, okay? Remember the ejection fraction, guys? Ejection fraction. If the ejection fraction drops, let's say, for example, less than 50 or less than 50%, well, our patient will not be able to really pump effectively the blood from the left ventricle if there is poor ventricular function. If the ventricles are weaker, maybe because of the cardiomegaly, dilation, then the ejection fraction, the cardiac output rather, is going to be lesser, okay? And so it's not going to cause the heart to work harder, referring to the cardiac output. Whereas the cardiac output is basically the end result to the strength of the myocardial function. It's not the other way around. Now, what about letter C? Heart overload. What is that? Well, this is not really a common term that is used in the concept. It's somewhat kind of vague in a manner. It's not really specific to the hypertension. Not specific to hypertension. All right, so our selection here is letter A. Higher afterload, wherein there is higher resistance, is elevated in the circulation. All right. All right, I hope that you're able to get the rationale. Let's take a look into the next item. What non-modifiable risk factor for hypertension should a patient identify to show effective teaching? All right, your task here is to identify that non-modifiable risk factor for hypertension should a patient identify to show effective teaching. Is it A, high sodium, B, sedentary lifestyle, C, tobacco use, D, family history? So we are being asked right now about non-modifiable risk factor. It simply is asking you to identify something that can't be altered. Okay, so we have high sodium, sedentary lifestyle, tobacco, family history. Correct answer here is letter D. All right, non-modifiable. You cannot alter that. Okay, it is genetic predisposition. Okay, so if the person has a genetic predisposition, there's nothing you can do about it. Genetic predisposition, no, nothing you can do about it. So what you can do here is to just do some other lifestyle changes that could potentially lessen your chances of developing any more complications because of the hypertension here, guys. So the high sodium diet is something that you can modify. Low sodium diet. Sedentary lifestyle, you can encourage the patient to do a lot more physical activity, exercise. Tobacco use, yeah, you can do smoking cessation. Okay, let me just write those because those are important stuff. Okay, high sodium intake, then you're going to limit in the diet. Sedentary lifestyle, encourage exercise program. And then for tobacco use, you're going to have to encourage smoking cessation. Smoking cessation. Yeah, you can start with that simple conversation with a patient. Hey, are you interested to really stop smoking? And most of the time that they're going to end up going back to cigarette smoking, it's because of the fear that they're going to gain a lot of weight. And also with a, probably they don't have enough support or support persons or support group maybe that will not really push them into stopping the bad habit. And so yeah, just initiate that simple conversation and then tell them that, hey, we can provide you with some alternatives up until you're going to completely stop smoking in the long run. So usually it will start with a reduction in the amount of cigarettes, maybe a few more sticks, and then it will probably taper until they're going to discontinue doing a lot more of the cigarette smoke. And so, yeah, it's quite important, guys. Now, let's move on to the next question, number 4. When educating a patient, newly prescribed captopril, what is the most crucial information to include? Wait a second here. When educating a patient newly prescribed with captopril, what is the most crucial information to include? Is it A, eat foods high in potassium like bananas, B, drink more fluids if experiencing dry mouth. C, stand up slowly to avoid dizziness. Or D, check blood pressure in both arms before taking the drug. What is your answer here, guys? Captopril. I'm seeing C's. Okay, very good. Yeah, the correct answer here is letter C. Stand up slowly to avoid dizziness falls because of its side effect, orthostatic hypotension. Excuse me. Tried to control myself for not sneezing. Can't wait to have this cold gun. It's self-limiting, and so it will go away, but I have to suffer, I guess. So let's take a look on letter A. What is this letter A? Eat foods high in potassium like bananas. It is going to be contraindicated. Why? The captopril is what? It is an ACE inhibitor. And you know that it can cause increase in the potassium level. We don't want to really do that. It's not going to help the patient. Okay. And letter B, drink more fluids if experiencing dry mouth. Well, dry mouth can occur, but increasing the fluids or more fluids is kind of like counterintuitive, right? It's it will what? The patient will be gaining some more fluids inside, right? If they're going to increase their fluids. That's not what the goal is for the treatment. We're not going to treat the dry mouth with fluids, increasing fluids, but probably they can use sugarless gum, or let's say, what else? Sugarless gum or sugarless or hard candy. They can do that in order to prevent the dry mouth, but not really increasing their intake of fluids, because that would be counterproductive to what we are giving them. Now, what about letter D? Check the blood pressure with both arms before taking the drug. Well, before we're going to have to administer that, they should be monitored once in a while, but it doesn't mean that we have to take the blood pressure every time on both arms. That's not going to be necessary, okay? So this is going to be a necessary step. Both arms. Not usually, okay? Now, our answer again is stand up slowly to avoid dizziness and falls because of that hypotensive effect. And it's going to be a safety issue, guys. This is going to be a very common test question to be asked in the NCLEX, making sure that your patient is kept safe. Again, your role here is to educate the patient to rise slowly and to ask for help if they need to use the bathroom when toileting. This is a very common occurrence in the US. Lots of falls, especially in the elderly population because of the antihypertensive therapy. So many falls, guys, and I can't believe the amount of falls that we had experienced way back in the unit where we worked, because our population is mostly like 75 years old and maybe hundreds. I've had like 3 shifts in a row that I've been taking care of like 4 patients that were like older than 100 years old, and so that's kind of be tough, right? And so you got to be careful. You maintain safety in your patient, especially when you're treating them with antihypertensive medication. Moving on to the next question here. Before giving propranolol to a hypertensive patient, the nurse should review which patient history detail. The question states, before giving propranolol to a hypertensive patient, the nurse should review which patient history detail? Is it A, daily alcohol use, B, peptic ulcer disease, C, reactive airway disease, or D, myocardial infarction? The question states, before giving a propranolol to a hypertensive patient, the nurse should review which patient history detail. Is it A, daily alcohol use, B, peptic ulcer disease, C, reactive airway disease, or D, myocardial infarction, or MI? Okay, I mentioned this earlier, but it was kind of subtle. Yeah, virtuous lady answered letter C. Yeah, the correct answer here, guys, is letter C. This is what we call as reactive airway disease. This is the newer term for the asthma. We don't want to give the propranolol, which is what? A non-selective beta blocker. Remember about what I said earlier, that it can cause bronchospasm. So make sure that you're reviewing the patient's medical history. Patient history detail. So if they have a history of asthma, this is huge. You're going to look for that medical history in order to keep your patient safe. All right. Alcohol use, it's actually going to be is not really a contraindication. Okay. So let me write down here, daily alcohol use, not a contraindication, but is discouraged. Okay. We want to educate our patient to cut their intake of alcohol. Okay. It's not a contraindication. However, we're going to discourage them from taking more alcohol. All right. What about letter B? Peptic ulcer disease. Peptic ulcer disease is not directly affected by propranolol. Not directly affected by propranolol. Now, what about letter D? Myocardial infarction. The myocardial infarction is actually not going to contraindicate the use of the beta blockers. Okay. The beta blockers will be prescribed. Let me just put RX there. It is prescribed after MI because it has cardioprotective effect. Cardioprotective effects. And what is that cardioprotective effect? Well, it can decrease the workload of the heart. Beta blockers. Okay. Beta blockers. It will decrease the workload. Let me just put heart's workload. And decrease O2 demand. And that is why we're going to see the beta blockers as part of the therapy in order to prevent any more recurrence of the myocardial infarction. Okay? I think I have to shift my color on my pen here. Red is way too angry. I'm going to try changing it to the blue, black, or Yeah. So again, our answer here is letter C, asthma. It is contraindicated. The medication propranolol is contraindicated for use in the reactive airway disease, or known as the asthma. Okay. All right. Let's move on to the next question. Question number 6. How should the nurse address possible white coat hypertension in an older patient? The question state, how should the nurse address possible white coat hypertension in an older patient? Is it A, advise reducing stress levels, B, teach the patient to monitor and record blood pressure at home, C, schedule regular clinic BP checks, and D, inform about major dietary changes needed? Let me reread the question. How should the nurse address possible white coat hypertension in an older patient? Is it A, advise reducing stress levels, B, teach the patient to monitor and record blood pressure at home, C, schedule regular clinic blood pressure checks, and D, inform about major dietary changes needed? Let me see your answer, guys. I'm seeing Anna answering letter B, also Ojunwa, Loveland, Ojimba, Walter. I hope I did not misread you or mispronounce your name. James answered letter B. Okay. Have you heard of the white coat hypertension, guys? This is rare, but actually it's real. It's real but rare, I should say. Okay. I hope that's not way too dark. Let me see my ink color. I think I'm going to use this one again. So the correct answer here is letter letter B. Okay. The patient will end up with elevation of the blood pressure once they show up in the clinic. This is expected of these type of patients, okay? They're going to have elevation when they are in the clinical settings. However, when they're going to be checking their blood pressure just by themselves at home, their blood pressure readings will be much more normal, okay? And so with this type of question here, yeah, we are going to teach the patient to monitor and record the blood pressure at home. That would be the most effective way of checking their blood pressure. So maybe you can do this by video conferencing, something like that, or maybe a phone call, or maybe just simply provide them the medical equipment and let them record it. Okay, that would be best in order that they can do it without stress. Okay, now if we had answered letter A, advise reducing the stress, well, this is going to be beneficial, but it's not going to be specific to diagnosing the white coat hypertension. Okay, so this is beneficial, but not specific. Not specific in diagnosing white coat hypertension. All right, so that is wrong. What about letter C? Schedule regular clinic blood pressure checks. Well, we already know that the patient has a white coat hypertension. So BP readings in the clinic will just aggravate things. So it will not be helpful. Not helpful. So this is wrong as well. What about letter D? Inform about major dietary changes needed. Would that be necessary? Yes, it is necessary, but it's not specific. The white coat hypertension is going to occur. Their blood pressure will skyrocket. It will go up once they are in a clinical setting, when they're going to be assessed by a medical professional face to face, their blood pressure readings will go up. This is a rare type of hypertension, but this is rare but a real kind of disorder. All right. I haven't encountered this myself. I haven't. Trust me. Never had any of this case. I haven't even heard of this case with my coworkers. And so, yeah, thank you, Mary. And the best way to evaluating their blood pressure is just teach them how to measure their blood pressure in the home setting. So make sure that they are instructed properly how to apply the blood pressure cuff, how to maneuver, how to position themselves. Make sure that they are relaxed before checking their own blood pressure at home. Make sure that they're not doing something else while checking their blood pressure, that they are comfortable, that they're not crossing their legs, making sure that their legs are planted on the floor. And so let them do their own blood pressure check. Or let's say, for example, maybe a family member that is capable of doing that. That could be another alternative. If the person is an elderly person that would have some difficulty in managing the device, then a family member could help. Okay. So that is the best way in addressing white coat hypertension. Let's move on to the next question. When giving the first dose of oral labetalol to a hypertensive patient. Thank you, Miracle. When giving the first dose of oral labetalol to a hypertensive patient, what should the nurse do? Again, when giving the first dose of oral labetalol to a hypertensive patient, what should the nurse do? Is it A, suggest using a hard candy to prevent dry mouth? B, inform the patient about possible headaches? And C, advise calling for help if experiencing palpitations? And D, assist the patient when getting out of bed. What is your answer here, guys? Labetalol. Okay. Okay, let's go through the options here. Suggest using a hard candy to prevent dry mouth. Well, this is not a common issue. Not a common issue with labetalol. So we are going to eliminate letter A. What about letter B? Headaches. Inform the patient about possible headaches. So this is also less common. Less common compared to dizziness and hypotension. So we're going to eliminate that as well. What about advice calling for help if experiencing palpitations? What about letter C? So letter C is also not a primary concern in the labetalol. Not a concern in the use of labetalol. Not a concern with labetalol. Remember, guys, that this is a beta blocker, right? Beta blocker. It can reduce the heart rate. It can also reduce the blood pressure, right? Don't forget, it's a beta blocker that is non-selective. Reduces heart rate, reduces blood pressure, and the adverse effect is what? Bronchospasm. Okay, so we have our answer here, which is letter D. advise or assist the patient when getting out of bed, because they're gonna get what? Possibly become hypotensive, or known as orthostatic hypotension. Okay, I can't spell. Orthostatic hypotension. So when you are dealing with an older patient, make sure that they're going to have to call for help before they get out of bed in order to prevent falling or syncopal episode. Make sure that they do that, okay? Orthostatic hypotension, we're talking about oral labetalol. Now let's move on to the next question, number 8. A patient admitted in the ER with minor injuries has a blood pressure of 184/92. What should the nurse do first? A patient admitted in the ER with minor injuries has a blood pressure of 184/94. What should the nurse do first? Are you going to start an IV access and anticipate giving antihypertensive drugs? Or B, recheck blood pressure after initial assessment? Or C, discuss hospital admission for blood pressure control? Or D, educate about stroke risk from higher blood pressure? What do you think? Are you going to do A, B, or C, or D? Okay. What would be your answer here? Anna answered letter B, recheck blood pressure after initial assessment. Very good. That is the correct answer. Very good. Virtuous lady, you answered letter B as well. That is the answer. Letter B, recheck blood pressure after initial assessment. So your case here basically is in a patient. We are given just a very information here, very few information. Minor injuries, has a blood pressure of 184/92. So you are free to do a succeeding evaluation after the first blood pressure reading. So this is going to be done first. Make sure you are going to reassess, okay? Do not anticipate of so many other interventions before investigating further. You got to make sure assessment of blood pressure. Okay. If you're answering start an IV access and anticipate giving antihypertensive drugs, well, this is going to be not really necessary based on the high initial reading, but can potentially happen. And remember, guys, that this is possibly a patient that might be so stressed, right? And so potentially their blood pressure spike is caused by the high stress level, okay? So make sure that you are doing the reassessment first before doing something else, okay? So this could be possibly caused by initial BP. Possible cause is stress. Just being in the hospital is already stressful. Yeah, trust me. I don't want to be in a hospital. I've never been admitted in the hospital, and I don't want to be admitted. Yeah, initial BP, possible cause is stress. Minor injuries. Make sure you're gonna have to deal that first by reassessing. What about letter C, discussing hospital admission for blood pressure control? Is it too early to do that? I guess so. Yeah, it's so premature. Premature without further assessment. And letter D, educate about stroke risk from high blood pressure. Yeah, it is important, guys. You have to educate them after you have already done your reassessment and probably treating it if it needed to be treated. But our priority action here is to reassess. Okay? Make sure you do the reassessment first. Let's move on to the next. Number 9. A patient with a blood pressure of oh boy, let me correct that. Hang on a sec. Am I cutting out? Hello? Can you hear me okay? Page 550. Can you hear me okay? Hello? Let me type in real quick so I'll know. $550. Oh boy. Hello, hello, hello. Can you hear me better this time? Can you hear me better? Okay, good. Let me just fix this real quick. Page 550. 550 with a all right, how about that? That looks a lot better. It doesn't seem like a tongue twister anymore. All right, let me reread. A patient with a blood pressure of 260 over 145 mmHg in the ER complains of headache and double vision. What should the nurse do first? Is it A? Good. Thank you. Give acetaminophen for headache. B. Explain the importance of not stopping antihypertensives abruptly. Or C. Start IV access for antihypertensive medication. And D. Refer to social services for medication assistance. All right, I'm seeing letter C. Okay. In this scenario, yeah, you definitely need to start the IV access. Well, you don't have any other choice, right? But to do that letter C. Because if you're going to select letter A, the patient's blood pressure, aren't you scared with that number? That's quite a big monster right there. 260 over 145. Yeah, I've seen this kind of blood pressure in one of my patients before. It's going to scare the hell out of you. And so if you're going to do letter A, give acetaminophen for headache, it's not going to treat the hypertension, right? It is going to be a secondary intervention. Will not address the severe will not address the severe hypertension. Yes, it can mask the underlying condition, but you know what, James? With this kind of high blood pressure, probably the acetaminophen will not really work, because the problem here is the severe high blood pressure. So probably the headache will not go away. And so again, this is not really going to address the severe hypertension. It might potentially mask, you're correct about that. But then again, with the severity of that high blood pressure, probably the headache will not go away. Okay, so that will be marked as wrong. Explain the importance of not stopping antihypertensives abruptly. Yes, education is important. However, education can be done after we have addressed the high blood pressure that is so high to 60 over 145. Should take place after addressing, oh boy, why don't they invent a pen that would just do magic, right? Education should take place after treating the high blood pressure. HTN. Okay? So we are going to mark this wrong, even though it's beneficial, but we can do that later. Now, what about letter D? Refer to social services for medication assistance. So you're just like kind of blowing off your patient politely? No, you're not supposed to do that. Make sure you treat the hypertension first. Okay? Treat that first. And then we can do the rest of the other interventions. Okay? Too mild. The acetaminophen will not do anything about the headache. Yeah, I've had hypertension, and in some days when the stress is so high, headaches can come out, or it will occur, and sometimes it doesn't even go away, even 2 doses of the acetaminophen. So what are you gonna do? You have to self-medicate, or not really self-medicate, but you have to take the antihypertensive medication. All right. So what we need to do here is to treat the hypertension. Our issue here is going to be the circulation. Oh boy, why are you not doing that? Or the concern, rather, I should say concern is about circulation. Blood supply to the body organs. You need to deal with this because the other problems like headache, these are just symptoms that can go away once you treat the exact cause, which is actually the elevated blood pressure. All right. So make sure you treat the problem in the circulation. Make sure that there is vasodilation so we can resolve the other problems. All right. Start IV access for antihypertensive medication. Simply as that. Now, number 10, a patient newly diagnosed with hypertension is prescribed spironolactone. Which statement shows understanding? A, I'll eat more fruits and veggies, especially bananas and potatoes. B, I'll report any changes in heart rate to my provider. C, I'll use a salt substitute instead of regular salt. D, I'll lower the medication dose once I feel better. The question stated, a patient newly diagnosed with hypertension is prescribed spironolactone. Which statement shows understanding? Is it A, I'll eat more fruits and vegetables, especially bananas and potatoes? B, I'll report any changes in heart rate to my provider? Or C, I'll use a salt substitute instead of a regular salt? And D, I'll lower the medication dose once I feel better. Are you supposed to do that? Or teach the patient? Or is that a good understanding? Guys, please be careful. Which statement shows understanding? And of course, this is about the use of the drug. Okay. Our correct answer here, guys, is letter B. All right. Don't worry, guys, if you're committing errors today. Don't worry. We all will learn. Letter B. Why? I'll report any changes in heart rate to my provider. Because if they are taking a spironolactone, remember, guys, that spironolactone is a potassium-sparing diuretic. What does that mean? Potassium-sparing diuretic can conserve potassium. Conserves potassium. It can increase the potassium level in the bloodstream. Hyperkalemia, right? When the patient's level goes up, this can now affect the heart rate of your patient. So if they're gonna feel like, hey, I feel like my radial pulse is getting slower this time, or I feel like I'm about to pass out. So you make sure that they are going to report these changes once they are taking the spironolactone. This is a good sign that they understood about the side effect. So this means patient understood the side effect of K-sparing diuretic. And this is what we are looking for. I'll report any changes in heart rate to my provider. If you answered letter A, I'll eat more fruits and vegetables, especially bananas and potatoes. These are food items that are rich in potassium. And we are not going to encourage the patient to consume these food items, okay? So let me erase this. It's getting too crowded. Let me just do that instead. If you answered letter A is wrong. Oh my gosh. A is wrong. What is happening? My pen is possessed. Okay. Wrong. Food items are high in potassium, are rich in potassium. Something is wrong with my brain today. My brain-hand coordination is bad. Food items are high in potassium. Can we just simplify that? Okay. All right. So A is wrong because those bananas, potatoes are high in potassium. Letter C. I'll use a salt substitute instead of a regular salt. Remember about the salt substitute that I mentioned earlier? Salt substitutes are high in potassium. High in potassium content. Okay? So they're not supposed to be using that in their diets, in their meals. No substitutes. What about letter D? I'll lower the medication dose once I feel better. Yeah. Are you this kind of patient that you're trying to lower the dose of the prescription? Are you this kind of patient, guys? Any of you guys? Are you one of these? Are you this kind of patient that will adjust the dose on your own without checking the doctor? Yeah. This is going to be not a... It's not reflective of understanding regarding the spironolactone therapy, okay? The patient should not adjust. Should not adjust. Dose. Adjust the medication dose. All right? They should not be doing that. Make sure they consult the doctor first. Consult the doctor. Okay? Consult the medical provider. Let's just put MD or the medical provider. All right. So I hope that you're learning from all these different ins and outs of the antihypertensive therapy because there are so many of these, really. So let's move forward to the next option, next item right now. Make sure that we are gonna get battered with all these medication considerations. Now, which finding in a hypertensive patient would require immediate intervention by the nurse? Is it A, blood pressure of 150/90 mmHg, B, serum potassium of 4.2 milliequivalents per liter, or C, heart rate of 55 beats per minute, and D, new onset of confusion? All right. Which finding in a hypertensive patient would require immediate intervention by the nurse? Is it blood pressure of 150/90, B, serum potassium of 4.2, C, heart rate of 55, D, new onset of confusion. I'm glad that I'm seeing a lot of letter D's right now. Looks like your brain is working great today. Congratulations. Your brain is working great. All right. Said require immediate intervention. Do you think letter A is needing immediate intervention, 150/90? No. This is a very common high level blood pressure in most of the inpatients, okay? This is elevated, but not gonna require immediate intervention, but doesn't require immediate intervention. When I'm talking about immediate, it has to be done within a span of, like, let's say 15 minutes. That is my immediate, right? Within that time frame. In some cases, probably within 30, but in my practice, when I say immediate, it has to be done within that lesser time frame. 15 is my max. Usually 5. Yeah, I'm really on it when I'm dealing with a problem that is very critical. But again, this one is not a very critical issue. This is hypertensive, but not really critical. What about letter B? Serum potassium of 4.2. This is normal. Okay? Normal. Remember about the range that is 3.5 to 5.0 milliequivalent per liter. So we are gonna remove this one. What about letter C? Heart rate of 55 beats per minute. It was abnormal, okay? Abnormal, but not critical. All right. It can be normal. Okay, so exception. Let me just put that there. Exception can be normal in athletic individuals. All right. There's an exception to the bradycardia that is 55. We don't know if the patient is athletic or not, but it's not that critical. So if you have a patient that has a new onset of confusion, yeah, that is the correct answer. Letter D. Because if they're going to end up with some neurological changes, maybe disorientation or confusion, this is probably a sign that they are having a stroke. Okay? This is gonna be needing immediate medical attention. All right? So you're gonna have to really be careful in assessing your patient. Is this disorientation new? Is this confusion new? Or is this brand new? Okay? You got to make sure that you thoroughly assess your patient. And it said here, new onset. So it's specified here, new onset of confusion. So this is significant, guys. So you got to make sure that you are evaluating the patient right away. Intervene. Maybe the patient's blood pressure is skyrocketing and they're developing stroke. This is a medical emergency, okay? A medical emergency. All right. We're going to talk about the stroke in the next chapter. I hope that I'm going to be assigned to do this, but because my specialty is neuro. I like neuro. Let's move on to question number 12. Oh, number 11, is it, Adam? Oh, so this is supposed to be 12 then. I did the wrong numbering. So page 553. 553. So that's supposed to be 12. Let me just fix the number here. It's 12. This is going to be 13. And then this is going to be 14. And then 15. And then Yeah, we still have more to go, guys. And 17. And then we have 18. I hope I did not make any repetitions here. All right, let's go back. All right, question number 12. A hypertensive patient rather asks about the DASH diet. What should the nurse include in the teaching? A, increase intake of red meats, or B, limit dairy products to reduce fat intake, or C, eat plenty of fruits, vegetables, and whole grains, and D, restrict all salt substitutes. Okay, what is your answer here, guys? DASH diet. I'm seeing letter D's. Okay. I don't know what the DASH diet. Yeah, it's not quite common in some other countries, but DASH diet is very popular in the US. So we need to know what this is. So the DASH diet is basically diet. It stands for dash. Ooh, my brain and hands, for some reason today, are not talking. I probably am having a stroke right now. Just kidding. Dash diet. So that's dietary approaches to stop hypertension. So that's what it meant. Hypertension. Dash diet. Approaches, dietary approaches to stop hypertension. So let's talk about the letter A. Increase intake of red meats. The red meats are known to be high saturated in fat, and so this is supposed to be limited. Should be limited in the diet. And the reason for that, it's because they have high saturated fat content. So this is going to be eliminated. We're not supposed to increase the intake of red meats. What about letter B? Limit dairy products to reduce fat intake. Okay? Limit dairy products to reduce fat intake. So this is supposed to, in the DASH diet, we are going to encourage them to intake low-fat dairy products instead. Okay? There should be low-fat dairy products. Okay? Because if there's that, this will also reduce the high blood pressure. Now, if we are answering letter C, eat plenty of fruits, vegetables, and whole grains. This is basically the primary source of food items that will be low in sodium, okay? So we're going to encourage them to eat plenty of fruits, vegetables, and whole grains. This is going to be our emphasis in the DASH diet. So let me write this down here. DASH diet. What are the food items that will be encouraged here? Well, these are the following, guys. One of those would be fruits, vegetables. Another would be, thank you, virtuous lady. Also whole grains. and also lean proteins. And basically, our end goal here is to lower the blood pressure. Now, if you had answered restrict all salt substitutes, well, the salt substitute is not universally restricted here. Our focus here is to reduce the sodium intake from all sources. Okay, because if we are only restricting all salt substitute, this could only mean to what do you call to replace. We're only replacing we're only wanting to have alternatives for the sodium intake in order that we can decrease the blood pressure, but it's not going to do that. It's not going to really control the blood pressure, okay? Because like I've said earlier, it's going to elevate the potassium level. Remember about the salt substitutes or alternatives? So the end goal basically with the DASH diet is to, again, reduce the blood pressure, okay? By what? Reducing the sodium intake. Fruits, vegetables. Yeah, thank you, Vinus Redoren. Approaches to stop hypertension. Less sodium content in the food items. All right, moving on to number 13. What information should a nurse provide a hypertensive patient starting on hydrochlorothiazide? Is it A, take this medication with a full meal, or B, report any muscle weakness or cramps, C, avoid drinking more than 1 liter of fluid per day, or D, expect your urine output to decrease? I'm glad that you're learning today, Loner Ali. The question stated, what information should a nurse provide to a hypertensive patient starting on hydrochlorothiazide medication? We always refer to this as was HCTZ, hydrochlorothiazide. So what would be that instruction? Is it A, take this medication with a full meal, or B, report any muscle weakness or cramps, or C, avoid drinking more than 1 liter of fluid per day, or D, expect urine output to decrease? Good Lord. Thank you for answering letter B today. That is the correct answer. Why? Why letter B? Why? Well, because if they have muscle weakness, or if they are developing cramping, or let's say, for example, this is a sign that they might have what? Hypokalemia, all right? Manifestation of hypokalemia, low potassium level. Remember about the hydrochlorothiazide effects. It will cause excretion of sodium, water. Why did I put a plus sign in my water? Okay, that's new. Water and also potassium. So these are known to be excreted when the patient takes hydrochlorothiazide. They're going to have hyponatremia. There's also going to be excretion of water and excretion of potassium. And so weakness in the muscle and cramping are signs that there is hypokalemia, and they should notify, they should call the doctor for these manifestations. All right, so this is our correct answer. What about letter A? Take this medication with a full meal. It's not required to be taken with a full meal. Not required. It's not going to cause more absorption. No, it doesn't. What about letter C? Avoid drinking more than 1 liter of fluid per day. This is kind of like excessive restriction. This is kind of strict. If I'm the patient with this 1 liter fluid restriction, I'd be so mad. So this is excessive restriction, very rigid. All right, way too much. This is an overkill. What about letter D? Expect your urine output to decrease. Why would it decrease? When you are giving a diuretic, the urinary output will not decrease, but it will increase. It's a diuretic, guys. Please, so don't forget that. Again, you're going to have to assess or measure the urinary output of your patient. Guys, as early as now, keep this in your mind. If you're going to administer any kind of diuretic, you got to be conscious in measuring the output. Make sure that you do it strictly. Measure it accurately. Don't just do estimates, let's say ×1, ×2, ×3. That would not be safe for this patient. So make sure you are going to measure accurately the volume that has been excreted by the patient. Thank you. Hydrochlorothiazide can cause electrolyte imbalances. Like any other diuretic, it can lead to electrolyte imbalances. All right, same thing with the loop diuretic or the potassium sparing diuretics. You have to keep an eye into the lab values periodically in order to keep safe ranges. Okay, now moving on to number 14. A patient on amlodipine. Okay, let me go back. We have a question from Loner Ali. Could C be correct if patient is a heart failure patient? Avoid drinking more than 1 liter. You are right. If they have a worsening heart failure and if they needed to be placed in this kind of fluid restriction, this can be appropriate. You're correct. But in this scenario, it's not applicable. Okay, you have a good point right there. Very good question. Thank you, Loner Ali. Moving on to number 14. A patient on amlodipine for hypertension complains of swelling in the ankles. What should the nurse suggest to alleviate this side effect? Is it A, stop taking the medication immediately, or B, elevate the legs when sitting, or C, drink more water throughout the day, and D, take your medication with food? A patient on amlodipine for hypertension complains of swelling in the ankles. What should the nurse suggest to alleviate this side effect? Is it A, stop taking the medication immediately, or B, elevate your legs when sitting, or C, drink more water throughout the day, or D, take your medication with food? I'm seeing letter B. Very good. Letter B. Very good. The correct answer in this test item is B. Elevate the legs when sitting. Okay, why? The reason for that is that the calcium channel blockers, amlodipine, has that side effect, a common side effect that is easily treatable. Okay, so you're going to teach your patient to make sure that when they are in a recliner, make sure that they're putting their legs on pillows to allow drainage and venous return. So this can reduce the swelling. Okay. Now, what if we answered letter A, stop taking the medication immediately? No, not safe. This will be unsafe because potentially it can cause rebound hypertension. Guys, the same thing with the other antihypertensive medication. The patient should not immediately stop the antihypertensive drug because this can lead to rebound hypertension. So make sure that they're going to talk first with their medical provider before they discontinue taking. Okay, so this is wrong. What about letter C? Drink more fluid, drink more water throughout the day. Well, this is not addressing the swelling of your patient. So we're going to eliminate that one. Let me erase this. So letter C does not address the edema. Yeah, you're just kind of like blowing off the patient right here in this instruction. Drink more water throughout the day. You're not addressing it. Now, take your medication with food. Nope, it doesn't do anything about the absorption at all, so we're eliminating that one. There's no association with food. Okay, it also does not affect edema. Does not address the edema. Okay, so we are left off with letter B, elevation of the legs when sitting. Okay, guys, please don't forget we're talking about the calcium channel blockers. This is a very common side effect. But it doesn't mean, guys, that in the long run, if the patient's swelling will worsen, this is the caveat. If the patient will report worsening of their ankle swelling, that is a different thing. Worsening of swelling is not a good sign. It could mean development of the heart failure, or could be onset of heart failure. Okay, please take note of that. Any worsening of the swelling could mean new onset of heart failure, or it could be worsening of the heart failure. So make sure that they will report any weight changes, maybe weight gain, or let's say the edema now is going upwards. Maybe there is leg edema, not just the ankle edema, or maybe there is now 3+, 4+ edema. That's not going to be a good sign. And so this need to be addressed accordingly once there is worsening. Okay, let's talk about number 15. What should the nurse include in the care plan for a patient with hypertension and a history of falls? Is it A, encourage daily weight-bearing exercises, B, assess orthostatic blood pressure regularly, or C, recommend a high-protein diet, or D, limit fluid intake before bedtime? The question asks, what should the nurse include in the care plan for a patient with hypertension and a history of falls? Is it A, encourage daily weight-bearing activities, B, assess orthostatic blood pressure regularly, C, recommend a high-protein diet, and D, limit fluid intake before bedtime? You're answering letter B, assess orthostatic blood pressure regularly. Yeah, very good. That is the correct answer. Okay. Assess orthostatic blood pressure regularly. Well, history of falls. Safety issue. So make sure that we are doing the orthostatic hypotension blood pressure monitoring regularly. And guys, I'm just going to add on here, orthostatic blood pressure monitoring is best done in the morning. Usually in the morning before the patient proceeds with their daily activities. Best done in the morning. Okay. And I've worked for the night shift for 14 years. Imagine that, 14 years. Would you be able to do that? 14 years of night shift, 12 hours, 3 times a week, sometimes 4 times a week. I've done a lot of these orthostatic blood pressure, especially during my shift before the day gets busier. So once I do my last shift assessment, like around 5 a.m. or 6 a.m., and this is the time that I start getting the medications for them before the breakfast. And I will just do my vitals, last set of vitals before I get off my shift. I do the vital signs, orthostatic blood pressure before they get out of bed. So make sure that you do this because all the hormones in the body are its baseline. Okay? When they are rested, when they are sleeping throughout the night, their hormone levels are in their baseline levels. Okay? And so this is the best time to accurately do the orthostatic blood pressure in the morning. Okay? Now, if you had answered letter A, encourage daily weight-bearing exercises. Yeah, it can be important, but the fall prevention here is going to be geared towards checking, or rather, the checking of the orthostatic blood pressure will identify if the patient will have a tendency to have a low blood pressure when they get up. And so this is basically an identification, okay? Identifies the patient if they will have hypotensive episode with positional changes. Okay, changes, triangle with S. Identifies the patient if they will have hypotensive episodes with positional changes. So that's the reason why we're doing the orthostatic blood pressure readings, letter B. Now, letter C, recommend a high protein diet. Well, it's important, but it doesn't address the risk of falls. Letter D, limit fluid intake before bedtime. Well, it's not going to be limiting without we're not going to do that if there's no reason to really limit it. We're going to make sure that the fluid intake of our patient is balanced. We do not want to excessively limit the fluids in this patient because it can also lead to hypotension and dehydration. So, excessive limitation, or let me just put it this way, unnecessary limitation fluid intake limitation can also lead to dehydration. Let me just write it as DHN, short for dehydration, and hypotension. So if it's not warranted, don't do it, okay? So we're not going to limit the fluid intake if it's not required, if it's not needed, if it's not the presenting problem of our patient. So we're not going to do any of the limitations. So our correct answer here, guys, is letter B, assess orthostatic blood pressure regularly. Okay, so our intervention here, or our goal in this test question, is to prioritize the assessment that is at risk to fall, especially that we are dealing with probably administering any antihypertensive medication. And so make sure that we are keeping the regular assessment to early identify the hypotension. That's just the way how I put it. Okay. All right. So I believe there is probably two more. So let's just move on with the next question. A hypertensive patient reports taking licorice root for stomach issues. What should the nurse advise the patient regarding the herbal supplement? The question states, a hypertensive patient reports taking licorice root for stomach issues. What should the nurse advise the patient regarding this herbal supplement? A, licorice root is safe for hypertension. B, stop taking licorice root as it can raise blood pressure. C, continue taking it but monitor your blood pressure daily. And D, increase your antihypertensive medication dosage. What is your answer for this item? Letter. What's the answer? The correct answer for this item, number 16, is, so we're talking about licorice stomach issues. So what should the nurse advise the patient regarding this herbal supplement? And we are talking about a hypertensive patient. I'm seeing letter C, B, C, B, and B. Okay, let's take a look into letter A. Licorice root is safe for hypertension. I've never tried that. Have you tried this kind of food item? I've never. And I've heard that it doesn't really taste that good. Sorry. I think I've known some nationalities that really like to take licorice. Are they Danish? I'm not quite sure. But I think there's like European nationality that they like to take a lot of licorice. Okay, no? All right, so let's take a look on letter A. Licorice root is not safe for hypertension. Okay, well, what should the nurse advise the patient regarding this herbal supplement? What is the answer? The correct answer is letter B. Stop taking licorice root as it can raise the blood pressure. Okay, so what it can do is actually it can counteract. Licorice counteracts antihypertensive medication. Yeah, Melrose, that's right. Herbal garlic is good for hypertension. I'm using that one. But I know Galicia is also good for hypertension. I'm not familiar with the Galicia. I have to read about more of that. Yeah, licorice root can cause high blood pressure. That's correct, virtuous lady, because it can counteract the antihypertensive medication. Okay, so they should avoid this one. They should avoid, and that's why letter A is wrong. Not safe. Okay, letter C, continue taking it, but monitor your blood pressure daily. So that simply means that you're not compliant if you're saying that, if you're telling that to the patient. Continue taking it, but monitor your blood pressure. Monitoring the blood pressure is important, but stopping the licorice root is necessary. So it should be stopped. Okay. Now, if you answered letter D, adjusting medication, increase your antihypertensive medication dosage. No, it is an unsafe practice. You should talk to the medical provider first before adjusting the dose. Unsafe. Patient should talk first with medical provider first. Okay. And anyway, guys, if you are going to see any of those options that will tell them that adjust your dose, okay, or something like that without any idea, or let's say without any additional verbiage that it's going to be referred to the medical provider, or let's say adjusting their own medication dosage without communicating, make it as a wrong answer. Okay, so eliminate that. All right, microphone back on. And so make sure that you're gonna eliminate those answers that will tell you increase the medication dosage if they don't see anything about consulting the medical provider. Make sure you eliminate those, because this is going to make your selection erroneous. So again, Our strategy here for this test question is basically to make sure we are educating them about the interactions, okay? About what the possible interactions that can occur when they're taking herbal supplements with a medication that they're being prescribed. Make sure that we are able to identify the possible effects, okay? And also, we need to give them clear instructions in order to avoid the substances that can possibly worsen their condition. So, let's say, for example, what is daily? Like this instruction right here. Continue taking it, but monitor. This is not like a sure teaching right here. I can sense it right now that the nurse giving this instruction is just like kind of winging it. It's not really being sure about what could possibly happen. What could possibly happen if they keep taking the licorice with the antihypertensive medication? So, yeah, there's that like kind of like doubt when they are giving that instruction. So remove that letter C. All right, so I believe, oh, there's two more questions. I thought that we're almost done. Yeah, I think so. Second to the last, what advice should the nurse give a patient taking clonidine for hypertension? Is it A, you can stop the medication abruptly if you feel better? B, use a salt substitute to enhance flavor in your diet? C, do not discontinue the medication suddenly to avoid withdrawal symptoms? And D, take the medication with a high-fat meal for better absorption. Question 16, what advice should the nurse give a patient taking clonidine for hypertension? Is it A, you can stop taking the medication abruptly if you feel better? B, use a salt substitute to enhance flavor in your diet? C, do not discontinue the medication suddenly to avoid withdrawal symptoms? And D, take the medication with a high-fat meal for better absorption. All right, I'm seeing letter C. Very good, ladies. The correct answer here is letter C. Do not discontinue the drug suddenly to avoid withdrawal symptoms. Clonidine. Yeah. That is the correct answer. The reason for that is the rebound hypertension can lead to rebound hypertension. So before they're going to decide on stopping taking the medication, they need to call the medical provider, have them tell the doctor that maybe they have some side effects that they don't want to really experience. And so around that time, the medical provider will be able to plan out what could be the other alternative if the doctor would really respond on maybe discontinuing the medication. So at least there is proper transition from one medication to the next. Okay, so that should be our technique in educating the patient. Do not discontinue the medication suddenly. If you have answered letter A, you can stop the medication abruptly if you feel better. This is pretty much similar to a question about antibiotic therapy, that when their condition gets better, if they have less coughing, then they can stop the antibiotic. Same thing. Eliminate that. We're not supposed to stop the medication regimen, or the patient should not discontinue the therapy once they feel better. They need to complete the regimen. All right. Letter B, use a salt substitute to enhance flavor in the diet. Again, salt substitute, this pertains to what? The alternatives, right? They contain potassium. Potassium ingredients. Okay. Letter D, take the med with a high-fat meal for better absorption. Did we mention about that? It doesn't require. Doesn't require high-fat meal for absorption for drug absorption. It was never mentioned. Okay. And it's not known to be therapeutic, or it's not known to cause more absorption of the drug in the GI tract. It doesn't. Okay. And lastly, we have item number 18. A patient with a history of hypertension is prescribed lisinopril. What adverse effects should the nurse teach the patient to report? Is it A, persistent dry cough, B, increased appetite, C, weight gain, D, difficulty sleeping? What do you know about the lisinopril? Okay. A patient with a history of hypertension is prescribed lisinopril. What adverse effects should the nurse teach the patient to report? Is it persistent dry cough, increased appetite, C, weight gain, D, difficulty sleeping? All right, the correct answer for this is the persistent dry cough. Accumulation of the bradykinin, which can kinin, not S. My hand has a mind of its own. Bradykinin. It can irritate the airways. Airway receptors. So that's why they're going to end up with that persistent dry cough. Increased appetite? No, because remember about the lisinopril, this can cause dysgeusia. That metallic taste, altered taste. Remember about that yesterday? Altered taste. Metallic taste. So around this time, there is that kind of like expected slight anorexia because of that altered taste sensation. Weight gain, nah, it's not really a known side effect to the medication. The same thing with the difficulty of sleeping. So we are going to select letter A. The answer is letter A. Okay, so our strategy here is to focus on the common adverse effect of the medication. So again, review the pharmacology, the common side effect of the medication, and of course, we're going to have to teach our patient about these side effects so they will know what to report to the medical provider. Again, education is key, guys. All right? It's very important that we need to educate our patient. And the education doesn't stop during the admission. It is going to be an ongoing process. Even though the patient has been in the hospital for maybe 20 days already, and during the discharge, the education will continue. All right? Make sure that we follow through and let the patient verbalize what they understood in order that we can assess, are they getting the correct information, or did they retain the good information that we gave them? And so this would be the highlight in our patient care. And so that's it for today, guys. We will be meeting again tomorrow for another session. We will be posting the topic in the thumbnail. And so I really enjoyed our discussion today. I hope you did as well. I hope that you're learning. And so I'll see you again tomorrow at 9 p.m. Eastern time for more NCLEX questions and more discussion. We're still gonna NCLEX questions are pretty much similar to what we've been doing. Yeah, I might put it in there. Thank you. Thank you so much, Melrose. James, yes, I'll be putting some of the original multiple choice questions, and I will add like the NGN test questions. But the goal really here is to make sure that we are assessing your understanding of the basic concepts, because if you do not understand the basic concepts with the mere multiple choice testing, it would be difficult for you to go into the NGN, because pretty much the NGN test questions, let's say SATA, they're pretty much like multiple choice. And so actually, I find the NGN test questions a lot easier compared to the previous NCLEX test questions. All right. So don't neglect those test questions that are multiple choice, do not, please do not, because they're actually the basis of your learning. Okay, so you got to make sure that you're able to ace those first and then focus into the SATA questions. Maybe the bow tie, that's quite easy. Matrix, oh, that's easy, guys. And so I really encourage you to read into the recent test exams with multiple choice. I don't want you to read the older ones though, like say previous or older than 20,000, or let's say older than the 2015, because most of the concepts there are no longer applicable. And so I would not recommend reading those very old multiple choice. I would use those multiple choice questions that are quite recent, within the last 2 years. Okay, so that would be my recommendation. So I'll see you again tomorrow, and you have a pleasant day ahead, and you take care. Bye-bye. Thank you. Whoops.